excellent talks that are lined up by a number of excellent speakers. We're going to cover some heart failure therapy, some cardio-oncology, some diagnostic issues, and I have we're four panelists here. So I'm Saad Hussain, I'm a heart failure and transplant cardiologist at King Faisal, and with me is Dr. Mohammed Sabbah, the VP of Faiz Shahid, and let's start. So, Mohammed.
Good morning, everyone. I'm honored to present Dr. Dermot Feller, Medical Director of Cardiovascular Imaging, Director of HCM Hooker Sport Cardiology Center, Atrium Health, Charlotte City, North Carolina. You are most welcome, Doctor, for the second presentation today.
Thank you so much, and thank you to the Saudi Heart Association. This meeting has been just phenomenal, and it's great to make some new friends here, so I appreciate it. So I'm going to spend the next 15 minutes talking about rapid versus conventional uptitration of heart failure management. Here are my disclosures, and they're not relevant to this talk. My learning objectives, I'm going to very briefly just define heart failure and review global burden of disease. Briefly talk about current medical management options, and then the meat of the talk is going to be on risks and benefits of various initiation strategies for guideline-directed medical therapy. So heart failure is, according to the updated guidelines, is defined as a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. And we recognize that heart failure is a very serious condition that is treatable, and we just need to make sure we accurately classify and identify heart failure in order to successfully manage these patients. You know, we used to talk about systolic heart failure and diastolic heart failure, and these definitions have advanced. So nowadays we talk about heart failure with reduced EF, an EF with less than or equal to 40%, mildly reduced EF, 41, 49%, preserved EF, greater than 50%. We also have a new definition of heart failure with improved ejection fraction, where it previously was less than 40%. And now greater than 40%. And we recognize that patients can transition from one category to another, but that we need to address our medical management based on these. And so we also recognize that there are different stages of heart failure. Stage A being those at risk of heart failure, those with hypertension or diabetes, for example. Stage B being those who have some abnormalities, such as reduction in EF, evidence of elevated filling pressures or increased BNP or troponin, but who do not have any symptoms. Stage 3 is symptomatic heart failure, and then stage D is advanced heart failure. So heart failure is very common. 1 to 3% of the adult population have heart failure. The overall prevalence is increasing, primarily being driven by an increase in heart failure with preserved ejection fraction. The mortality numbers are pretty shocking. You know, 30-day mortality, 2 to 3%. 5-year mortality, 50 to 75%. And unfortunately, we've seen these numbers for many years now, and we can improve these if we do better. The cost of heart failure is significant, about $25,500 per year in treating these individuals. So if we look at the medical management, you know, our standard paradigm for many years was we would start people on an ACE inhibitor, beta blocker, maybe an ARB if they're intolerant, an outpatient would get some spironolactone. But really, we've a lot more in our armamentarium these days. And I'll draw your attention really to the first column here. These are the relative risk reduction. If we use an ACE or an ARB, 17%. ARNI is an additional 16%. Beta blocker, 34%. MRA, 30%. And SGLT2 inhibitor, 17%. I think the important point here, though, is that these are additive, right? So every additional medication that you get your patient on, there is an improvement in this. And if you can get a patient on all of these, there's a 74% relative risk reduction over 2 years, and this is about 26% absolute risk reduction with a number needed to treat before. So incredibly good numbers if we can actually get patients on these medications. So what are the recommendations for the various stages? Well, if you're a patient who's in stage A, you're basically going to address their risk factors, right? The blood pressure, the diabetes. If it's stage B, you're going to start with a ACE inhibitor, and a beta blocker. For stage C and D, which is going to be the kind of focus of most of the talk here, we've got a lot of different things that we can offer. ARNIs, beta blockers, MRAs, SGLT2 inhibitors are all class 1. Now we're going to start these medications on our patients, and if their ejection fraction improves above 40%, then we're just going to continue to monitor them over time. We're going to leave them on those medications. For those patients who do not improve, if they're African American with NYHA class 3 or 4, we're going to talk about putting them on hydrochlorothiazide and isosorbide dinitrate, and we're going to be thinking about ICDs and CRTs. And those who continue to worsen, get into stage D, we're going to be talking about mechanical support and transplant. For patients with mildly reduced ejection fraction, our options are not as plentiful. We took class 2A indication for SGLT2 inhibitors, and the rest are all class 2B. It's important to emphasize again this category of heart failure with improved ejection fraction, because we get these patients in our clinic all the time, right? Our ejection fraction went from 30% to 50%. I want to come off all my heart failure medications. The answer is no. We know from this data that these individuals will deteriorate again, so we want to keep them on their guideline-directed medical therapy. For those with preserved ejection fraction, our treatment options are essentially the same as those with mildly reduced. So only SGLT2 inhibitors have a class 2A indication. So let's now get into the meat of the talk, which really is the risks and benefits of various initiation strategies here. And this was our conventional strategy, right? We would start with either an ACE inhibitor or a beta blocker. We would increase that to the maximum tolerated dose, then we would add in the next one, and then hopefully in the outpatient someone would remember to add in an MRA, and someone would remember maybe we should switch them to an ARNI and then SGLT2 inhibitors. And so this was kind of how we approached it, but the data really suggested that this was the wrong way to approach it. So this is looking at beta blockers, specifically carvedilol and Copernicus trial, and we can see that very early on these curves are diverging, right? And so these people were gaining mortality benefit very early after treatment. And they were also, even in the high-risk group, they were seeing better safety parameters here. And so this table is a little bit busy here, but let me walk you through it. Here we've got the endpoint report, the bottom of the all-cause mortality or heart failure, or hospitalization. Here we see the effect at 8 weeks, and at 8 weeks we see a significant improvement. And again, at 8 weeks we see a significant improvement. So the comments here, major separation of the Kaplan-Meier curve at 4 weeks. The point being that if you don't start these medications early, that these patients are missing this mortality and heart failure rehospitalization benefit. What about eplerenone? Well, we can see similar story here. This is the EMPhASIS HF study. Again, a significant divergence in the Kaplan-Meier curve here very early on, significant benefits at 30 days. Again, the EMPhASIS study, similar story. All-cause mortality, sudden cardiac death, we see a significant benefit at hazard ratio at 30 days. So significant change at 30 days in both of these studies. What about sacubitril/valsartan? Pioneer HF study, same story. Significant benefit within 30 days. The Paradigm HF study, significant effect at 30 days. And then finally, if we look at the SGLT2 inhibitors, the DAPA HF trial indicated there was a 49% reduction in events at day 28, and the Emperor Reduced study showed a 24% reduction at 12 days. And if we did not start these medications early, they double the risk of having some adverse event. So really, all of these data and all of these different drug categories tell us that if we delay starting this medication, we're actually depriving our patients of benefits of these medications. So we really need to think of this as 4 pillars of enhanced survival and heart failure reduced ejection fraction, and recognize that delaying initiation will impact survival in our patients. This was a study published in 2020 comparing studies, a number of studies that use conventional therapy with beta blocker. I'm sorry. I usually shout loud enough anyway, so. This compared conventional treatment with beta blocker and ACE inhibitor versus what we talked about, that quadruple therapy, the ARNI, the SGLT2 inhibitor, the beta blocker, and the MRA. And look at the results here. On top, this is projected survival after the age of 55 years, and the difference between conventional and comprehensive therapy was 6.3 years, 6.3 years additional years of life. Predicted event-free survival was 8.3 years. So a massive difference between what we used to do and if we use this comprehensive therapy. So don't cheat our patients out of years of survival and improve symptoms. We need to be using quadruple therapy. And this is really just to emphasize, bring that point home, looking at the hazard ratio of all of these parameters when you're using the comprehensive versus the conventional therapies. So how good are we at doing this? Well, this is pretty sobering data. This is the CHAMP-HF registry from the United States, 5,000 outpatients with heart failure with reduced ejection fraction from 150 practices. And you can see in the red, orange, whatever that color is here, you can see the ACE inhibitor ARNI here, 26% not on any of these medications, the beta blocker, 32, 33%, and 2/3 not on an MRA. So dramatic, significant numbers not on these medications. Now, if we look at many of these trials, the CHAMP-HF, the Pinnacle, they're both US registry. The QUALIFY is an international registry of about 7,000 patients. The ESC heart failure study was a study of over 12,000 patients in Europe, and the Biostat study was a study in Europe also. And you can again see these numbers in the US, really not great numbers. In Europe, a little bit better. ACE or ARNI about 90% here, beta blockers about 90%, MRA about 67%. So certainly better in Europe. But if you actually look, these are patients on any treatment, but if you're actually at target, then these numbers drop down very dramatically. You know, a lot of these numbers less than 25%. And these are a little bit older trials. What about in 2023? This was a paper published just earlier this year, the Evolution Heart Failure Study. This was looking at databases in the US, Sweden, and Japan, looking at patients who had initiated guideline-directed medical therapy within 12 months of hospitalization. And you can see here, these are the different types of medications in Japan. Black is ACE inhibitor ARB, purple here is beta blocker, yellow is MRA, and in Japan they do really well. Not so good in the SGLT2 inhibitor or the ARNI. Sweden, a little worse. US, not very good at all. But again, if we're looking at trying to get to target dose, this bright green number, you know, or darker green number, I should say, very few people at target dose there. So we're still not doing very well. And why is this? A lot of this is related to the fact that there's inertia, right? When a patient comes in, they're hospitalized, we start them on some medications, they're sent out to outpatient clinics and nobody makes any changes to the medication. And so this was the thought behind the STRONG heart failure study. How fast can we safely titrate these medications? This was a multinational, randomized, open-label trial of hospitalized heart failure patients using high-intensity versus usual care. The hospitalized patients were enrolled prior to hospital discharge if they were not on optimal guideline-directed medical therapy, and they could have either heart failure preserved or heart failure reduced ejection fraction. And so essentially in the high-intensity arm, they rapidly up-titrated these medications to maximum doses over 2 weeks, or at least half optimal dose prior to hospital discharge, right, and compare this to standard local practice. And so this is a little bit of busy graph here. This is the ACE inhibitors, ARBs, or ARNIs. The high intensity groups are in these colors, the usual care, and the more blue colors, and patients who are in the dark red are on full optimal dose. So here we see before optimization, hardly anyone is on full optimal dose. By day 90, almost over 50% are on full optimal dose, and over 80% are on over half optimal dose. Now compare that to the usual care. The dark blue here, compare that to here. 2 or 3% get to optimal dose. And it's the same story whether you look at beta blockers or mineralocorticoid receptors. So really, you know, using usual care, we usually don't get these patients on these medications, certainly not in optimal doses. Now there was no serious, a big concern is, okay, I've got a sick patient in a hospital, I'm going to hammer them with all of these medications at once. What's the effect in terms of side effects? There was no serious or fatal adverse side effects, although there was quite a lot of other potential adverse events, such as hyperkalemia, hypotension, renal impairment. So 41% in the intensive group versus 29% in the standard group. But look at the difference at 180 days. So 15% of the high intensity group met the primary endpoint of all-cause death or heart failure readmission by day 180 versus 15 versus 23% in the usual care, a highly significant difference there. So while yes, we did see hypertension, hyperkalemia, and things like that, we certainly saw significant improvements in outcomes. So this is feasible, and really we should be doing it during the initial hospitalization. I think I've got maybe one or two slides left. So essentially this is a potential algorithm. Day one, we initiate all of the medications at low dose, and we gradually up titrate. Now in the real world, we also know that patients can have low blood pressure, and maybe we need to kind of stagger how these are introduced depending on their blood pressure, if they've got renal impairment or concern for low output. But by the time they leave the hospital, we really want to try and get them on all of these medications. And so yes, there are risks with rapid initiation that we talked about, but we really have to recognize the benefits here. We're talking about a decrease in mortality and rehospitalization. So use these three pillars, titrate to maximal doses, but most important is to get them on all four rather than getting them up on high doses. Remember these numbers in terms of relative risk reduction of 74%, and really we should focus on not cheating our patients out of years of survival and improve quality of life. Thank you. Apologies for that.
Thanks, Dr. Fallon. Now I'll introduce one of our national experts in heart failure, and Dr. Khadija Adam is advanced